My name is Lindsay Miller. I'm a volunteer and a papillary thyroid cancer survivor. So Amy Franco is an assistant professor and investigator with the Center for Childhood Cancer Research at the Children's Hospital of Philadelphia. Dr. Franco directs the newly established Pediatric Thyroid Cancer Translational Research Laboratory. She earned her PhD in cancer biology from Vanderbilt University and conducted her postdoctoral fellowship in genetics of thyroid cancer at Memorial Sloan Kettering Cancer Center in New York. Her research interests include the molecular biology and genetics of thyroid cancer and improving quality of life and survivorship outcomes for thyroid cancer. Dr. Franco is a 2012 ThyCa Research Grant recipient and has spoken at many ThyCa conferences. So thank you for being with us here today, and I'll turn it over to you.
Thank you so much for that introduction. I'm sorry that I'm not there with all of you. This is one of my favorite meetings to attend. I am also a lifelong ThyCa member, as I am a 25-year survivor of follicular thyroid cancer. So I was diagnosed during young adulthood during my senior year of college. But unfortunately, or fortunately, the last week I was in DC all week advocating for cancer research. I was on Capitol Hill and doing lots of different Hill visits and just did not, unfortunately, this year have the time to be able to do that and then get down to Houston. So I apologize, I'm remote, but I swear I'm there in spirit with all of you for this meeting. And thank you for those that stuck around and are going to join us for this afternoon last session. So what I'm going to talk about today is really kind of try to get into and dissect a little bit about genetic and molecular tests, what they tell us, and more importantly, what they don't tell us, and kind of some of the things that I think kind of moving into the future. So I'm going to try to break this down as much as I can. I don't have a ton of slides, so we should have plenty of time at the end for Q&A, and we can also go back to some of the slides if something doesn't make sense. But please feel free to interrupt if there's something that just doesn't make sense and really needs immediate clarification. So what are molecular tests? I think often we hear about these and, they're referred to by their brand name, the Afirma test, ThyroSeq, ThyGenX, Thyromere. But how are these different versus genetic testing? And I think that this is something that's really critical for us to talk about first getting into it, because they very much are testing for different things. They'll give us different information, and how we use that information is very different. So first, what we need to talk about is germline versus somatic. And I know this can get very overwhelming. I'm going to try to walk through it slowly, but I think it's really critical for us to first understand really the differences between what is a germline mutation versus what is a somatic mutation. So first are germline mutations. These are mutations that are present in every single cell of our body. These usually are not completely catastrophic mutations, as I'm going to talk about when we start talking about some of the somatic mutations, because these are usually compatible with life. But what they do is they increase our likelihood or increase our risk for developing things later on in life, be it cancer or other predisposition diseases that can affect. So and when we're talking about germline mutation, every single cell has that mutation, and they're located in our germ cells, so in the sperm and egg. So we have the ability or propensity at times to be able to pass this to offspring. So these are things when we talk about genetic testing, and when we talk about looking at what's in our DNA and we do it off of a cheek swab or off of the blood, what we're looking for are these mutations that are present in every single cell. Like I said, many times these don't necessarily cause a disease in and of themselves, but they predispose us or make us at risk for developing something later on. These are in contrast to what we talk about when we say somatic mutations, or when we talk about doing molecular testing associated with thyroid cancer. What we're looking for are these somatic mutations. And these somatic mutations are only what are found in the tumor cells. It's only tumor cells. And in the case of what we're talking about today, it's only mutations in thyroid cells. And the reality is, it's not even a mutation that's seen in every single thyroid cell we have. It's found specifically in our thyroid cells that have become cancerous. These are not things that we can pass on. It's only in our tumor. So this does not mean if we have a somatic mutation in our tumor, it only affects that one small subset of cells within our thyroid, and it's not something that we pass on to our children. It's only these germline mutations that we pass on to our children. So first thing I want to do is talk a little bit about germline testing. And then we're going to go into the somatic testing, or those molecular tests that I had mentioned before. So germline testing is usually done with a genetic counselor. We can now sometimes do this type of germline testing through some of these commercial companies, 23andMe and many other places can now do germline testing, and they can either find sometimes these genetic mutations that may predispose us. So Dicer1, P10, MEN2A, MEN2B, BRCA mutations. These are some of the big name mutations that we see come up in the germline. And again, put us at risk for developing not only thyroid cancer, but many other types of cancer potentially. And these are something why it's always should be done with a genetic counselor is because this doesn't mean you will necessarily get a disease associated it. And it also doesn't mean you are guaranteed to pass it on to your children. So it really is helpful to have the genetic counselor or someone to really go through these results with you to kind of digest them and translate them and talk about the risks that are associated with this. For one, developing a subsequent cancer yourself, but then also the risk that you may have of passing this on to children. And alternatively, what was the risk that you actually inherited this from someone ahead of you? And how do you look at your relatives that were before you, whether it's cousins, grandparents, parents, and whether they actually had disease, cancers or diseases, and what happens? There's also another thing that I'm going to talk about, and I'm going to mention it here, and we'll talk a little bit at the end. It's called SNPs, or these SNPs, and we don't need to go into all of the molecular biology or the genetics that's associated. But these, these are called small nucleotide repeats, or small nucleotide polymorphisms. What they're called isn't really important, but know that this is not a mutation in a specific gene, but instead these are patterns in our DNA, in the blueprint for life, that may indicate whether you've got risk for developing cancer or not. We don't know what a lot of these do. We don't even know how they increase risk and whether they're actually driving the risk itself or whether they're just a marker that correlates with risk. It may not be that these SNPs or SNPs in and of itself will cause cancer, but just having them may be indicative that you're at a higher risk or not. And sometimes, even though we find thyroid cancer that may track in families that's not associated with a specific mutation in one of these genes, that means you have the risk factor. It may mean, in fact, that having one of these SNPs has increased your risk or is associated and marks the fact that you might be at increased risk for actually getting somatic mutations down the road. So it's a very complicated process. There's so much that we still don't understand, and that we don't understand whether these are causative and really leading to the cancer, or are they just correlating with it? And they may be doing something else besides causing cancer or increasing risk, but just having these markers in and of themselves may indicate that you're at greater risk. So they can be powerful, but they have to be powerful. They're only powerful in the right context, and when you can have appropriate counseling to really kind of understand the pros and cons and what those risks are that may be associated with it. Just having the presence of a SNP or some of these other mutations is not in and of itself cause for panic. And this is why I say most often, and really, I truly believe should be done with a genetic counselor so that you have somebody that can really talk you through this entire process. So risk prediction. These are some of the hereditary cancer syndromes and some that are associated with thyroid cancer. And specifically what I talked about, some of those genes, P10, APC. And this is just kind of a very high view summary to show you that these can be associated and increase your risk for development of thyroid cancer. But I want you to look and really take out of this that even if you have a mutation in some of these genes, P10, for example, it means your lifetime risk is between 3 and 10% for developing cancer. It doesn't mean it's a death sentence. It doesn't mean it's a guarantee. It just means that we know you're at risk, and it probably makes sense to monitor you a little bit more carefully. Again, the importance of why having these tests done with a professional, a genetic counselor, so that they can help understand what are these lifetime risks, and to not induce panic just because we found some of these mutations. So this kind of gets to what happens if there's other family members that have had thyroid cancer in my family. Um, do they have those risk alleles, those SNPs, SNPs that I was talking about? Or maybe they have other factors that we haven't yet figured out. And who should be tested. So I think, if you have a family tree where you yourself have thyroid cancer, your parents, one of them did, a grandparent did, cousins do, then there may be something within your family that could be indicative that there's a risk or a risk allele there. The problem is we haven't identified all of them. And even if you have germline testing, because many members of your family have developed thyroid cancer, it doesn't mean that we're actually going to be able to identify and find exactly what that marker might be that's associated with that risk. So genetic testing can't tell us everything, unfortunately. And there's still so much for us to learn and still figure out. So that was the big bucket that I wanted to present about genetic testing. But now let's move over and start talking about molecular testing, because I think this is most commonly what we think about when we see testing, when we hear about testing, when we've had an FNA, when we've had our tumor tested. This is the type of testing that's happening usually. The genetic testing is not usually happening on our tumor. And actually, for them to do genetic testing at the tumor, they have to have normal tissue or the normal thyroid or blood or cheek swabs, something that wasn't tumor to compare it to, so that we'd actually know that it was germline. But when you have an FNA that undergoes molecular testing, your fine needle aspiration before surgery, or have testing done after surgery, specifically on the tumor, more than likely it's molecular testing. So when we do this before surgery, and when we do this at the time of biopsy, or when you're having your fine needle aspiration, these tests, the first thing to know, we've only validated them in adults. So my lab focuses on on pediatric thyroid tumors and thyroid cancer. We are very interested in how we can apply some of this molecular testing to the pediatric population. But we do know that the mutations that we find in pediatrics are subtly different than what we see in the adult population. So the molecular tests that we have that are used primarily in the adults and have been validated there may not pick up all of the mutations that we see in pediatric thyroid cancer. So those of you listening that have had molecular testing with pediatric in the pediatric or even the young adult setting, sometimes the mutations that we see in adults aren't present, or aren't as prevalent as what we see in pediatric. So these molecular tests don't always give us the same answers in the pediatric setting as they do in the adult setting. But we use these to try to stratify patients, to have a better idea when they're undergoing biopsy, particularly those that aren't definitive, looking at the FNA under the microscope to say, yes, it's cancer or not. We can complement those initial pathology tests with these molecular tests to see if we can increase the knowledge and the likelihood of it being cancer, so that we know and we can better advise patients of whether they should undergo surgery or whether they may be better suited for surveillance and watching and waiting. But what we're doing with these molecular tests are really looking for specific mutations or changes that are occurring just in your tumor cells, and taking that information to see, can it increase our knowledge and prediction of whether this has a high probability of being cancer, again, considering total thyroidectomy, just a medium probability and maybe a lobectomy and watch and see, or is it a low probability of cancer? Excuse me, and should we consider surveillance? So this kind of gets into a little bit of how we use these molecular tests. Again, this is looking at it in the spectrum of pre-surgery when we're looking at a nodule that we're not quite sure what it is, and we take the FNA, and then, we have the cytologic, or this is the pathology diagnosis, where there's atypia of unknown significance, whether there's a follicular neoplasia, which means that the follicular cells, the thyroid cells, look different. We know they're growing differently, but we don't know whether they're really truly cancer yet, or whether they have this suspicious, or that they're suspicious for malignant cells, or again, suspicious for cancer. When we get these pathologic diagnoses and looking just at what the cells look like, this is the cancer risk. And again, this is in the adults, of whether they would actually truly have a cancerous tumor within the thyroid. So when it's atypia of unknown significance, it's only about 14% of those that actually truly are tumors and cancerous. With the follicular neoplasia, 27%. And when we do have suspicious for malignant cells, it's still only just over 50% of those that truly are a cancer that needed, and that we would really want to go and take out. So this molecular testing, or these panels looking for specific mutations, this is not a comprehensive list. And each of those molecular tests that I showed you at the beginning, Afirma, Thyroseq, Thyromere, they each test for some subtly different mutations or different markers and changes within the tumor cell. But what we can find is that when using these, we can increase our confidence of whether these are truly have a risk for cancer or not. And this really can help guide our clinical management of whether we really want to undergo a total thyroid, or recommend undergoing a total thyroidectomy, because we know total thyroidectomy, if we do this and it turns out not to be cancer, these patients now have to undergo or have to be treated with lifelong thyroid hormone replacement. So it's really beneficial if we can increase our confidence in whether this is going to be truly a cancer or a non-cancerous lesion up front, so that we can stratify patients for a less invasive type of surgery, and hopefully be able to preserve their quality of life if we can take a less radical approach, and particularly use just a lobectomy and preserve some of the normal thyroid that may be there. So what drives thyroid cancer, and why are we looking for these mutations? And I don't want to go into all of the biology and make each of you a geneticist and a molecular biologist at the end of this. But the problem is that we know papillary thyroid cancers, PTCs, versus follicular thyroid cancers tend to be driven by mutations in different types of genes. We know, not again, without overwhelming all of you, that MAP kinase activations, you may hear that, MAPK, MAP kinase activations, drive a lot of thyroid cancer. But how that pathway becomes activated is different between FTCs versus PTCs. PTCs are by far the most common and primarily are driven by these BRAF V600E mutations. So this is why often we can, even if we have suspicion for PTC, even testing for BRAF, which is present in about 60% of papillary thyroid cancers, if we see this mutation, we're really confident that indeed this is truly a papillary thyroid cancer. The same thing when we see RET PTC rearrangements, or when we see different fusions, we're usually very confident that this is indeed a cancerous tumor. The problem arises with follicular thyroid cancers because they are driven by a lot of mutations that we see both when they're a cancerous and a true FTC and when they're also benign adenomas. So FTCs are very big. I'll call them problem child, and that's the subtype of thyroid cancer I myself had, because even our molecular tests can't give us a real true high confidence of whether they're an FTC or not. And FTCs can only be confirmed by surgery and seeing either vascular lymph node lymphatic invasion into the tumor, or that tumor itself has kind of popped outside of the thyroid capsule. So FTC diagnosis is still a work in progress. And even though molecular tests can help us a little bit, primarily the molecular tests are helping us with the diagnostics of papillary thyroid cancers. And anaplastic thyroid cancers, most often, by FNA, we would not need to have any of the molecular tests. We would notice this by just looking at ultrasound or by the FNA biopsy. But we do see that ATCs, or anaplastic thyroid cancers, are driven by a lot of the same mutations that we see in either the FTCs or in the PTCs. But what I want to say is that the presence of these mutations, especially, don't mean everything. And these mutations and these pathways are absolutely critical for normal thyroid growth. The problem happens is when these mutations are present, these pathways become turned on or turned off all of the time, and that's why we get cancer. So just a little bit to think about is, if you think about thyroid cells, they're the car, right? And every car, whether it's a race car, a normal car, or one that's going to crash into the cancer wall, it needs to have brakes and it needs to have an accelerator, right? We need to be able to stop the car when we need to, and we need to speed it up when it's necessary for, activity of those cells. Every single cell needs to have that ability to kind of slow down and speed up. But cancer happens when either the brakes get stuck and completely turned off and you can't activate them. So think of it as both your emergency brake and that my kids always call the oh shit brake, right? When that doesn't work, and when your brakes, your normal brakes don't work. And those are what we call tumor suppressor genes. You need to have both aspects of those brakes removed before you get cancer, and have no brakes whatsoever, both your emergency brake as well as your pedal brake. The other aspect are what we call oncogenes. That's what BRAF is. That's what RAS is. These are mutations where just one mutation actually is enough to get that accelerator locked in the on position and crash us into this cancer wall. Most often, when we see things like anaplastic thyroid cancer or poorly differentiated thyroid cancer, they have both an oncogene, BRAF, RAS, those mutations which get the accelerator stuck on. But that means they've also lost the brakes, these tumor suppressors, which we think of as P10 or TP53. So they're in a really sad state where the accelerator is stuck on and all of the brakes have been inactivated. So this is why sometimes, even after an FNA, doing these molecular tests on the tumor can give us an idea of what's going on with the biology of that tumor. Does it only have the accelerator stuck, or has it only lost the brakes, Or does it have a really, really bad situation in which both the accelerator's locked on and we have no brakes? And this can give us an idea of whether this tumor is in what we call the well-differentiated state, where it responds really usually well to therapy and maybe even radioactive iodine, or is it progressing to a more progressive, poorly differentiated or anaplastic state where we really need other treatment options? So this is where, in the context of doing these molecular tests, even at the time of surgery, and understanding what the tumor looks like, this is how we can utilize these molecular tests to try to stratify or have an idea about what we would use for a therapeutic approach after we do surgery. And this slide is really busy, but I just wanted to tell you the other thing about these molecular tests and why identifying which of these accelerators is mutated or turned on can be really important, because we have a lot of therapies to some of these accelerators, or oncogenes, as we say. BRAF has molecularly targeted therapies. So if we know BRAF V600E is present and BRAF is the accelerator, we have different therapies that we might be able to use and specifically target that tumor. The same thing for MEK, ERK, these other proteins, MET, FGFR, RET fusions, TRK fusions, so NTRK or RET fusions. We're not going to go through all of these inhibitors, or all of these different types of changes, but by utilizing these molecular tests, this can give us indications if the surgery and radioactive iodine therapy don't work, that there may be other options in our arsenal and other treatment strategies that are used in other tumors outside of the thyroid that have these types of mutations that we may be able to use for these patients. The reality is none of this is a crystal ball, especially when we think about germline testing. These are only predictions. These are not guarantees. And just because you have a germline mutation does not mean that you're definitely going to have cancer or really bad cancers. Again, they're just predictions. So this is why I am a strong, strong proponent of utilizing germline testing, but only with the context of having an expert that can help advise you and these genetic counselors that can help translate these risks and what it really means. And to translate what the relative risks are versus the absolute risks, which is beyond the conversation today. Um, and also, even looking at the molecular test, just because you have a BRAF V600E mutation doesn't mean that it will become a poorly differentiated tumor or that it may not respond to therapy. You may respond very well to surgery and radioactive iodine. Again, it's not a crystal ball and something that is a definitive prediction. It really is just assessing risk. And especially with some of these mutations that we can detect through molecular testing, it doesn't mean your tumor will become poorly differentiated. It doesn't mean it will progress. But sometimes having that knowledge, if it does happen, gives us a bigger arsenal of how we can treat these tumors, and better ideas of agents that we might be able to use if you unfortunately become one of those people that develops distant metastasis or recurrent disease. I'm also going to tell you, and especially with emerging therapies, that the tumors are really complicated. Not only do we have these blue tumor cells within the tumor, but we have a lot of other cell types that come in there and that are part of the tumor. There's lots of these orange normal cells, the normal thyroid cells that are right next to it that are doing and sometimes helping, sometimes hurting the tumor. We also have this extracellular matrix. So this is collagen you'll sometimes hear about, or a fibrotic response. And we also have a lot of immune cells that come in. So sometimes we can't target the specific mutation that we see in the tumor cells, but sometimes we have opportunities to target some of these other cells. Sometimes when we talk about using anti-angiogenic therapy, that means we're trying to target the vascular or the blood cells there. So there are other ways that sometimes even that we can't determine or we don't get the information out of a molecular test, there are sometimes other opportunities to target other aspects of the tumor, such as the immune cells and immune therapies, or immune modulating therapies, or these anti-angiogenic therapies that sometimes can be very effective for different subtypes of thyroid cancer, or at least give us another option to buy us time in the context of poorly differentiated and also anaplastic tumors. So that was a big overview. And I think what we've got plenty of time for question and answer. So what I'm going to do is I'm going to stop sharing my screen so that we can have a discussion. But if there's any of the slides that people want me to go back to or that we want to.
So I just have one question. Do
Go
they
for it,
use
Katie.
when they do an FNA? I had papillary thyroid cancer. When they do the FNA, do they do molecular testing, or is that something you have to request? That's my question. Because how do they know it's papillary versus follicular like you had and all that kind of stuff?
Okay, so follicular versus papillary is based on just the way the cells look under the microscope. That's how we make the diagnosis. So follicular versus papillary have the cells just look different, and we won't go into all of that. We can talk about some of it, but papillary have what we call nuclear inclusion bodies or nuclear clearing. The cells just look different, often both at the FNA level when they take just a few cells out and look at them under the microscope, or after the tumor comes out and the pathologist looks at what the tumor looks like under the microscope. So with that being said, molecular test is not always standard of care at an FNA. It really depends on who you're seeing, whether you're an adult or whether you're a pediatric patient, whether you're being seen in a location where they see a lot of thyroid cancer, or whether you're being seen in a smaller center or with an endocrinologist that hasn't seen a lot of thyroid cancer in the past. I will also say, unfortunately, a lot of this depends on whether insurance will cover getting the testing or not. So I will say there is a lot of push now, and I'm actually involved, part of, my advocacy being in DC. One of the things that I'm going to be involved with in the next couple months is pushing for what we call biomarker bills. And biomarkers can be a bunch of different things, but biomarkers are associated with cancer and can help tell us whether cells or abnormal cells may be cancer or not, or any other disease. And the molecular tests fall into these biomarker testing. So there's a lot of push now to have this universally covered by insurance, because in many cases, this can help guide us on definitively diagnosing whether something's cancer or not. But it also, as I talked about, can help guide us on what kind of treatment and how extensive our surgery should be up front. Is a patient a candidate for a lobectomy just to remove that suspicious area that might be a tumor? Or should we be much more aggressive on the front end and really think about a complete thyroidectomy from the very beginning? So not everybody has molecular testing at the FNA. And depending on where you're being seen, not everybody even gets the molecular testing at the time of diagnosis when the surgery is completed.
Okay, thanks. I'm assuming you mean if you're like at a major medical, like MD Anderson or Stanford or UCSF, they might do it. But if you're somewhere else out in the suburbs and you're seeing an endocrinologist there, they might not do it.
Correct.
Okay, thank you.
That's the unfortunate reality.
Yes.
And I would say that also is the unfortunate reality, which means why some of these molecular tests may not be able to tell us even more, because there's probably lots of mutations out there that we don't know, or we don't know how often they're they would be seen in a thyroid tumor, and whether they would definitively tell us yes or no, it is cancer, because we're not testing all of the tumors. So the more tumors, even, and smaller sites that can continue to do research and identify this, I think will help fuel us in the future for developing better molecular tests, but also better prediction models of whether these are truly tumors or not.
Thank you. That was really helpful.
So I have a question, and I'm not sure if this is something that it's even being looked at, but I've read about mtDNA complex 1, that this is something that is being started to be looked at with cancer, with thyroid cancers. The other question is, does it pertain to any type of thyroid cancer? I'm in the oncocytic boat. So molecular are not great in the first place, so I don't know how the mtDNA, whether that even has any correlation with that. And then should that be measured before surgery and after surgery, or is after surgery enough?
So the first part is the research is in its infancy. It is primarily the MT is mitochondrial DNA. So we know oncocytic variants of thyroid cancer have more mitochondria. They just have, for lack of and I'm using this very broadly, the energy is very different in an oncocytic thyroid tumor, and energy is utilized differently. So that's why the mitochondrial are different. But this type of research is really in its infancy. We do know the mtDNA, and studying different types of mtDNA and understanding the differences could be beneficial in thyroid cancer as well as in other types of cancer. The reality is we just don't have enough baseline information to know how to use this information yet. So I think, in another 10 years, it will be very valuable. But we're just starting to, hit the tip of the iceberg in these investigations to really be able to utilize this knowledge and have any idea how it may be predictive or how we could use it for diagnosis in thyroid cancer.
Do you know who in US is even looking at it at this juncture? Does MD Anderson do anything with respect to that by any chance?
I don't know specifically. I mean, MD Anderson has some work in this. Sloan Kettering, I believe, is also doing some work, and potentially even in the University of Colorado, specific to thyroid cancer. But there's groups across the world and the globe that are becoming much more interested in the mtDNA just at large in cancer. And I think as more research is done, we'll be able to find ways in which we can hopefully apply this also to thyroid cancer.
And I'm just going to ask kind of follow up. So given that the mtDNA points to the mitochondria, would that be a somewhat valid assumption that it might have better chance in showing something in oncocytic, or is it am I completely off?
No, what I think the issue, I think it probably will be informative or potentially be informative for all tumors, but it's not going to be the same for oncocytic variants versus those that are not oncocytic variants. So I think this is where we're going to need to be careful in when we draw conclusions, and it'll be difficult for some of the recommendations that may come out, is because some of the mutations or some of the changes that we might see in mtDNA are going to they're going to mean something different in the oncocytic tumors than what they mean in classic papillary or classic follicular thyroid cancers.
Thank you very much. Appreciate it.
I've got an online question from Carrie. I don't know of any cancer in my family, and I have papillary thyroid cancer. Is there any testing I should have done on my son?
If there's none of it, I mean, if there is no history in the family, then probably not. I think just watching and being aware, this does not mean screening and having him constantly going in to look at the thyroid, but I think just a generalized awareness. But there really is in my opinion, at this point, and I'm not a physician, I'm a PhD, but I don't think that there's really, you know, a reason that without an other familial history to to have any tests done at this point.
I have a couple questions. So with the somatic mutations, what happens if you have a somatic mutation like BRAF V600E in multiple places? So in your thyroid and in like precancerous skin lesions, does that make you more prone to additional BRAF mutations in like other places, or does that mean that your pathway has been disrupted, like the MAPK pathway?
So it just means that the MAP kinase, yes, the MAPK pathway has been disrupted. It's interesting case, and we've just started to look at this. We don't know if it means it, well, what I will say, it doesn't mean you have a BRAF V600 or BRAF germline mutation. However, what it could mean is that there's something else that, you know, predisposes your cells that they just don't like to repair themselves quite as well, that maybe your DNA doesn't like to be proofread and corrected. Your spell check on the DNA blueprints just may not work as well. But it definitely does not mean that, you know, it's going to be mutated in multiple places. Having it in precancerous lesions in the skin is probably pretty common, just because the skin is constantly getting damaged. Our blueprints, the DNA is constantly being damaged by the sun. No matter how much we try to protect, it still is unfortunately just it's a cell type, our skin, that's constantly growing and constantly turning over, and it can be prone, unfortunately, and susceptible to getting mistakes.
And is there ever anything that you know about to see where that predisposition comes from for that pathway disruption?
Not that I know of. The only time that people would start to think about looking for something like that would be, again, maybe in a family where lots of individuals have had different types of cancer. And that could be suggesting or suggestive and indicate that maybe there is, you know, a germline mutation, predisposition mutation in something that one of these proofreaders of DNA. But in the absence of having a family history of it, it would not be something to look for in the germline. And sometimes the reality is we just have crap luck in some places.
Okay, and then I have one more question about the tumor testing. And I know there's different places you can test with, like Tempus and then through MD Anderson. Is there a difference in the mutation panels that are done through these different companies? And what's like the most extensive type of panel that you can get? Because I know there's like a full genome, which seems to be separate from these as well.
Correct. So the full genome and doing comprehensive sequencing where we look for everything is the most comprehensive. That's also only done for the most part on research protocols or done at big centers. Like we do it on some of our tumors here at CHOP, MD Anderson, sometimes Harvard, the Broad, like you said, MD Anderson. That would be the most comprehensive because that's going to look for a mutation in any gene that is located, anything, whether we know it's associated with thyroid cancer or not. It looks for everything. The panels are only looking for a select set of genes that we already know were associated with thyroid cancer or with other cancers, because there's thyroid specific panels, like I talked about, some of the Afirma, Thyroseq, things like that, Thyromere. And then there are foundation medicine and other types of panels that look for mutations that are associated with cancer. They may not have been shown to be associated with thyroid cancer. They were mutations that were common in colon cancer. Who knows? So any of these panels are not comprehensive that will detect absolutely everything. Which one's better? I can't tell you. Like I said, the most comprehensive would be to do complete sequencing, but this is the most costly. It's the most difficult to interpret because we all have mutations in lots of different things at any given time. That's just the nature of our bodies. And many times, many of those mutations will never lead to cancer.
So those full genome tests, those are something not routinely ordered, I assume. And so is that something people can get on their own, or how can you really do that if you're not part of like a research setting?
It's difficult to get that done. You really, a lot of it is, I mean, you talk to your physician, and try to potentially get enrolled. Sometimes this can be done on tumors after the fact. So most every place you would go, the tumor is saved. It's preserved in formaldehyde, and they put it in these little wax blocks to keep for anywhere from 5 to 10 years. They get locked in a closet somewhere. Some of these tests can be done on those tumors. It's a matter of asking whoever your physician is to try to do that. If they have the resources, have access to it. But the problem becomes, how does it get paid for? And this is something that we can't solve, and can't even totally address in this conversation. But the fact that so much of our healthcare comes down to costs and who's going to pay for it and whether insurance will pay for it. And often insurance will not pay for it, particularly if it's to find out why, to expand our knowledge so that we can help those in the future versus an immediate need because a patient has developed disease that's not responding to therapy and we need a new option. That's the unfortunate reality of the way insurance many times works. Okay, metastatic tumors and when they move. Sometimes, yes, they don't usually change the mutation, but sometimes they can acquire new mutations. So yes, with metastatic tumors and with things that have spread to other locations and are not responding the same way to therapy, or a person now with a tumor that's spread to the liver that doesn't respond to RAI any longer, sometimes biopsies to try to understand what is in that distant tumor can be beneficial, especially to see particularly what I was talking about with these targeted therapies, that if they've acquired a new mutation where there's a drug that's available to that mutation, then sometimes it can be helpful and beneficial to do testing again. But that's going to be very specific to the tumor, and a conversation that needs to be had with your physician as far as which are the best types of tests to look for. The chances are you're not going to find what we call a new driver, a new accelerator. Instead, you may find that there's a new accelerator mutation, or there's some sort of new mutation that's released more breaks, or so that really needs to be a specific conversation with your provider, but it definitely can be beneficial to understand if there's new mutations that have happened. Is it okay to wait, when you've had, these tests? Like I said, none of these tests are a crystal ball. And I think that it is okay. It's just a matter of what risks you're willing to take, how, and how this affects your daily life. If this isn't something in the back of your mind that's constantly gnawing at you, has this tumor grown? Has this tumor, that might have been cancer, but we're not sure and I didn't remove it. If it's not driving you crazy and you're monitoring and you're seeing with your physician that, TG levels aren't going up all of the time, other tumor markers that the tumor's not growing, then I think it's perfectly fine probably to watch and wait. Again, this isn't something that I would do without close consultation with your provider.
Hello, I have a question on that slide that you still have up, and I'm sorry if I got confused because of the image, but there's like a little squiggly line in the embryo under somatic mutations. Do somatic mutations occur at the embryo stage, or do they occur later in life, like as an adult, as like
Yep.
outside of our
It
parent?
can happen either way. So
Okay.
this, and I'm glad you brought that up because this is kind of a crappy, and I probably should change the slide. So this represents something that happened in the embryo, and that's why you see like a much bigger area affected. But most often these do not happen in the embryo. They happen later in life. It's crap luck, one cell in your thyroid that becomes mutated, or, one cell on your skin that becomes mutated, but usually it's later on in life. Like skin cancer is result usually of being exposed to UV radiation. So most often these somatic mutations do not occur at the embryo. They happen later on.
Hi, I have a question for you.
Mhm.
Is my understanding from what you taught us, and both the normal cells mutation and cancer cell mutation and are related to the gene mutation in the nucleus of the cells. But on the other hand, is my understanding, inside for each cell, in addition to have the nucleus, has the DNA. But for the mitochondria, you also mentioned, mitochondria also has the DNA. As my understanding, mitochondria's DNA, the number of DNA is smaller. So, well, so far I did not see any research pay attention on mitochondria's DNA's mutation. Is that true? So I think if the both the compartment or the parts has the DNA, then we cannot assume only nuclear DNA will have the mutation, particularly for the cancer cells. For cancer cells, nuclear has the DNA mutation. But as my understanding, for the mitochondria also has the 37 DNAs. It may also have the mutation, but I did not see any research on the mitochondria's DNA mutation.
So I guess I'm not quite sure. The mitochondrial DNA mutations and changes is something that's very new in the research field. And honestly, even 10, 15 years ago, we didn't appreciate how or what these changes meant. It's only recently with new technologies and including new sequencing and being able to find things that we could never find in the past, that we're starting to understand that these might actually be causative, or maybe maybe they just correlate. Maybe they aren't causative. We don't know the answer, but that these changes in mitochondrial DNA can also be associated with disease processes. But again, like I said, it's because a lot of our technology has just advanced so fast that now we can see things that we were never able to see in the past. And I think kind of think of it as TV. When you look at old movies and we couldn't watch them in color, you used to just, now when we watch them, we assume there was no color, but there was color. We just didn't have tapes that could see it. The technology is changing. So now we can see things, and especially see things in the DNA and see things in the cells that we were never able to see before. But now that we know they're there, we don't know what they mean. So we're still trying to catch up. In the past, and with the tests that I talk about, germline mutations, somatic mutations, those are most often looking at mutations that we associate with the nucleus, because the nucleus, nuclear DNA, that's the control center of the cell. We know there's lots of other things that are essential in the cell, just like in the human body, we think of the brain as the control center, but we know a lot of the other organs are just as important, and that they're doing a lot of things. So Right now, we're just kind of trying to put all of these pieces together and understand how it all works together. But the nucleus is where the vast majority of our DNA, the blueprints are. And when we talk about traditional germline and somatic mutations, we're talking about those mutations that are happening in the overall blueprints that are happening in the nucleus.
Okay, yeah, well, and then one more point, and I saw one paper recently. It says that they did the experiment. They put uh, the cancer cells nuclear and into a normal cell, and then the cancer cell and the nuclear of the cancer cell will die within this normal cell. So that means that means to me the cancer cells nuclear will not survive in the normal cell, and it may suggest that the mitochondria of the normal cell may play some role in the cancer and the normal cell metabolic process. I don't know. And my major is physics, is completely different, but this is my guess. Okay, thank you.
I think you answered one of my questions about whether you can have testing done on your tumor. If I had surgery 3 years ago, if I'm lucky, they saved my tumor and they could do the mutation testing on it now, because I'm pretty sure they didn't do any when they did the surgery.
Yes. Usually if the tumor is still around, sitting in an archive in pathology in a closet somewhere, they can do the testing. The biggest challenge is who pays for that testing and whether they would deem it medically necessary. Most of the testing that would happen on those probably would happen in the research setting of somebody wanting to know mutations.
Okay, do you know the approximate cost of some of these testings?
I don't, honestly, because I have no it you also like to do the panels, it has to be ordered by a physician. So even that probably has something to do with contract testing, and I have no idea. I'm sorry.
Okay, thank you.
So I have one more question, and I wanted to know, have you seen any correlations between neuroendocrine cancers and thyroid cancers, given that neuroendocrines have quite a bit of biomarkers? I know that there can be a neuroendocrine thyroid cancers, but that's very, very rare. Anything that you have seen from that angle? And I know that's not exactly what you do, but I was just trying to see if you maybe saw it in the research field, some kind of correlations.
Not usually. We usually see them pretty independent. Sometimes they have similar mutations, like we know the neuroendocrine medullary thyroid cancer is a neuroendocrine tumor, and it shares RET mutations and sometimes RET fusions, which we can also see with thyroid epithelial tumors, which are your traditional follicular thyroid cancers, papillary, the cells that come from the follicular origin. But as far as correlation and predisposing and things like that, or crosstalk, there isn't anything that I know of.
So it's not like neuroendocrine cancer, thyroid cancer, or found in thyroid is going to be eventually classified as something separate.
They
I
will
guess
be
I'm in the boat
classified
where I'm being
as separate because they come from different cells of origin. And that's something we didn't talk about. I'm sorry, I didn't mean to cut you off, but neuroendocrine come from a different cell type than a thyroid follicular cell. They're just different subtypes of cells that have gone to specialize to different roles in the body.
So sounds like the one in the thyroid from the neuroendocrine perspective would be more like a metastasis and not the origin starting in thyroid.
So the neuroendocrine that starts in the thyroid is called medullary thyroid cancer, but
Okay.
it doesn't come from thyroid follicular cells. It comes from the C cells in the
Medulla.
thyroid. It's a totally different type of cell within the thyroid. So that's why you can have a neuroendocrine tumor in the thyroid, but it doesn't come from the same type of cells as the thyroid follicular cell.
Yeah. And medullary is the only one that we know from the neuroendocrine perspective in thyroid.
Yeah.
Okay. Thank you so much.
Awesome. Thank you. Well, thank you everyone for joining.